My professor, our role model, our endodontist role model, Professor Dr. Ashraf Refai, Professor of Endodontics and former head of department Al-Azhar University. Dr. Ashraf is always leading in the field of conferences, scientific days, scientific events, and he's always doing this without any thinking about any other thing other than he's going to give a good scientific content. Thank you, Dr. Ashraf, for being here. It's our honor and pleasure. And our topic today is instrument retrieval, the do's and don'ts. Thank you, Dr. Ashraf, and you can start.
شغال كده؟ Okay. بسم الله الرحمن الرحيم. طبعا it's always a pleasure. Dr. Mohsen and Dr. Yusra and Dr. Hadil always get invited to these events, and for me they're an event never to miss. I always like giving the new generation a feel of what it's going to be like in their careers. So I know sometimes الحاجات اللي هتسمعوها هتبقى way above where you are right now. And I'm always interested to set the bar. يعني there's going to be people لما you set the bar really far away هينهاروا and they'll give up. I don't want these people. Okay? And there's people when you set the bar really high, they put it as a target and then they start moving towards this bar. And these are the people that are going to be successful endodontists or dentists in the future. So I know that you can see some really complicated cases, maybe that you've never seen something like this or even close to this. But المحاضرات دي بتفتح عينك to what's yet to come. Okay? سواء كانت في target as an endodontist, as an implantologist, as a periodontist, as a prosthodontist, it doesn't make a difference. You're going to hear a lot of lectures throughout these 2 days from different people. And the whole point is, it's like a compass. And أنا بعمل لك زي نوع من التوجيه. عشان, oh, I like this. I like intraoral scanners, so I'm going to be interested in that. Oh, I like endodontists, so I'm going to be interested in that. And then you start moving in that direction. So this lecture today is designed specifically for that. So here's my contact information. If you need anything, please do not hesitate. You can communicate with me on Instagram, Facebook, and all the other social media platforms. Right. So that's سؤال, the $1,000,000 question. احنا كلنا as endodontists want to know, why do instruments fractures? So you go to the different companies and they tell you, you can use our instrument for 10 times and you can use our instrument 15 times. And then where is الحق في ده? يعني where is it? Can I use it for 2 times, 5 times, 10 times? Is a molar like a premolar? Is a 4-rooted molar like a 3-rooted molar? Is a case with curved canals like one without curved canals? When people say things like you can use this instrument for 5 to 10 times, I become very, very weary. Because what about if I decide 6 times and this instrument fractures after 5? So this brings us down to the issue of, why do instruments fracture? So these are the things that can run through your mind at that point. The canal is curved. That's very nice. So that we can blame somebody else. So we say, the canal is curved. It's not me, it's the canal. The canal is narrow. Yes. The endodontic motor settings are wrong. Yes. Rotary instrument, نوعه وحش. Yes. The alloy, it's not the best type. See, if you look at all these reasons, have nothing to do with the clinician. It's always somebody else's problem. Narcissistic قوي احنا. You know, it's not my problem, it's their problem. Okay? So, but it's always the clinician's fault. In all cases, no matter what happens with the instrument separation, it's your fault. It's never the fault of the instrument, the motor, or whatever. Right. So the reasons why incorrect speed or torque, narrow curved canals, like I said, it's always your fault. That's my right-hand man, Dr. Mu'taz said that he's not here today, but yeah, I blame him for everything. Okay, so let's look at why instruments fractures. Instruments fractures for 2 main reasons. Number 1, حاجة اسمها torsional fatigue, and number 2, حاجة اسمها cyclic fatigue. No instrument breaks specifically just for cyclic or for torsional. It's always somewhere in between. Because you can't isolate both of these fracture modalities من بعض, because just putting it into the canal, it will be under torsional stress and under cyclic stress, and I'll explain the difference. Right, so when you have cyclic fatigue, what happens? عارفين لو جبنا a wire and we start doing this, what's going to happen after a specific amount of time? It will fracture. We all agree on that, yeah? So what happens basically is that when the instrument is being bent, the atomic bonds are being stretched on the outside of the instrument. And on the inside, they're being compressed. Go 180 degrees in the other way. What was compressed is under tension, and what is tension under compression. So what happens is the atomic bonds, they begin to spread apart. One of them fractures, it begins to propagate, and then you get an instrument separation. So in simple terms, that's how fracture happens using this modality. طب احنا بنعملش كده في الانسترومنتس في بق العيان. So why are you telling us this? So in the patient's mouth, okay, so this is what torsional fatigue, cyclic fatigue looks like. See? مش مهم, it's copper. It's the same thing for any other material. Right. Now, inside the patient's mouth, what's happening is the instrument is rotating 180 degrees and then another 180 degrees. So if it's in a curved canal, it's exactly like أنا عملت إيه كده, and then when it goes another 180 بقت إيه كده. So what you're actually doing, rotating an instrument inside a canal, is compressing one side, tensing the other, and alternating between them. Now, so because it's always very unclear عند الدكاترة, they mix between torsional fatigue and cyclic fatigue. This is a test that's very old. It's been on the internet for at least maybe 20 years, okay? And it's a torsion testing of an instrument inside a 90-degree curvature canal without being bound. يعني إيه without being bound? يعني instrument مش معشقة. All right? And let's just see how much time it takes for the fracture to happen. No force, no application, no in and out motion. Okay, you know, don't imagine that it's going to take a very long time. You're rotating these instruments at about 300 RPM. That's about 6 rotations per second. So if you remain 10 seconds inside, that's 60 rotations. That's not a small number. بس احنا عشان بنقيس زي ما كنا بنقيس بالhand instrumentation, it's just the same amount of time. Yes, but you never used to rotate 6 times. All right, so what's the difference? The other type of modality, it's called torsional fracture. When you insert the instrument inside the canal and it's tight, what's your gut instinct? What does it tell you to do? When you find resistance, بتعمل ايه؟ ها؟ علي صوتكم. بتطلعوا. Most of you, when you feel resistance, your natural instinct that builds in, and you try to apply a pressure. Very rare is the innate instinct of the doctor to remove the instrument. And this is very clear. Why is this the case? We teach you operative dentistry first. We teach you crown and bridge first, in which we tell you, if you find resistance, please apply pressure. You are the creator of a cavity. I give you a sound tooth structure. I tell you, create a class 1 cavity, class 2 cavity. So if you find resistance from the tooth structure, طبيعي ومنطقي جدا تعمل ايه? Apply pressure. So you learn this in 4th year, and then in 5th year we tell you endodontics. So obviously you're going to take this information and graft it on endo. When you feel resistance, what do? You apply pressure. Now the big difference between endodontics and operative dentistry is that you are not creating a cavity in endodontics. This is the main difference. In operative, I tell you, create a cavity. In endodontics, I'm telling you what? Enlarge an already existing cavity. To enlarge an already existing cavity means if it's resisting you, it's telling you, hey, don't do this. I can't take this. So the opposite is in endodontics. If you feel resistance, come out. Okay, and this is the main reason why instruments fracture, why you ledge, and why you perforate. Because your mind is telling you, you're the creator, but you're not. You're a canal enlarger. Big difference. So when the instrument gets put into the canal, it binds at the apical area, running at 300 RPM. Now what happens? Your mind tells you, I can see the instrument rotating, right? And it's rotating at 300 RPM at the coronal part of the instrument. But at the bound part of the instrument apically, it's not rotating at 300 RPM. It's rotating at less. So let's just give an example, 250 RPM. So what's happening that every rotation up there is less of a rotation apically. So what's happening is the instrument is being stretched, 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 and then what's going to happen? But because your mind is telling you, I'm applying pressure and I can see it rotating, then it's rotating at the same speed apically, which is not the case. Again, this is what it looks like. That's what the file looks like inside the canal when you're applying pressure. Now it's very important to visualize because we talk about torsional fatigue, we talk about cyclic fatigue, but I cannot, you as a dentist who's never seen cyclic fatigue, never seen torsional fatigue, cannot imagine it happening. Right, first case of the day. Now this was a very old case of mine. I just saw it 2 months ago. It's been 10 years since I'd done this treatment. It's a lower 8. العيان جاي لي he's telling me I want to do a lower 8 endo. I saw the canals on the x-ray. I was like أبوس إيدك, I don't want to do this case. All right? I'm a good endodontist, but don't push it. So and he's like so I tried to discourage him by doubling my price, and he said no, I'm willing to pay. So I'll give it a try. All right? And I went in and I was very careful. I realized I'm dealing with a very bad curvature. I did my enlargements, I did my glide path, and then there it is, 3 seconds into preparation. 3 seconds. Right. And then I did a bypass and then obturation. And you can see it's really nasty anatomy. Okay? Now, it took me something like 13 visits عشان أوصل للend result دي. الموضوع بقى قلب عند بقى وبقى, you know, it's a challenge. مش مهم, but I'm going to finish it. But and for me, just extraction would have been a much better option. Right. So let's analyze. You can see space above and below the instrument segment. Yes? What does that mean? Was it bound or unbound? Huh? Bound? No. طالما there's space above and space below, معناها it wasn't مش معشاء قوي. صح? So I would say this is most probably because of the narrow radius. This is probably fractured by cyclic fatigue predominantly. There's always a bit of torsional fatigue. So when you come to evaluate, it's very important because when we come to retrieve in the future, okay, it makes a big difference if there's عامل torsional fatigue في الموضوع أو cyclic. The more you're dependent on a cyclic fatigue fracture, the less bound it is, the easier it is to bypass and remove. Okay? So you need to analyze the x-rays before you start doing a retrieval attempt. Right. So which one of these, in your opinion, would be more prone to fracture? أنا واحد فيهم. Huh. 1, 2, 3, 4. مين رأيه 1 2 3 4. So لو أنا كنت رتبتهم in my opinion, the most difficult and the one that would probably fracture more predominantly would be number 2. يليها number 3. يليها إيه number 4. يليها number 3 وآخر واحد number 1. Sorry, I mixed up. This is the most prone to fracture. اتفقنا? The second one is number 4 is the second most prone to fracture. يليها إيه? Huh? This one and then number 3. Okay, so في عامل درجة الانجل والnarrowness of the curvature. Imagine لما بنيجي نعمل U-turn على سكة سفر ولما بنيجي ناخد اللي هي اللفة الكبيرة. Which one is more prone to accident? The sudden U-turn or the one اللي بعيدة? Sudden U-turn. Right. So this was a case, 37-year-old, instrument separated, Gayali in this case, and I removed the gutta percha, and this exposed segment, what do you think? Torsional fatigue or cyclic fatigue? Huh? Torsional, cyclic. Okay, let's just see, is it cyclic or torsional? So I bypassed and working length determination, and then I put in my cones. I couldn't remove it, and that's the end result. Okay? So here, in my opinion, there was a lot of space من الناحية دي. That's why I was able to bypass. Now, if I was not able to bypass, معناها إن ما كانش هيبقى في space around the instrument. بس كانت هي ماسكة برضو على distal wall. So it's engaging, but not as much. So I said, most probably this fractured above the curvature. So I was like, maybe it's a used instrument, not much binding. أنا حطيت في دماغي it's probably a cyclic fatigue fracture. Right, another case. جات لي patient, one of my old patients. She left my practice عشان I was too expensive. All right, and then she went to another doctor. She fractured the instrument and she came back. Okay, so when she came back, you see a 6 millimeter segment fractured in there. And then, what do you think? Sorry, what do you think this is? Be cyclic or torsional? Torsional, huh? 6 milli torsional. Yeah, there's a good piece of الحتة منها binding in the apical area, maybe coronally a little more space. So الدكتور رأيه maybe torsional. Okay, right. So there's the instrument, but you forgot the buccolingual curvature. You see, we always look in 2 dimensions. When I'm looking at the sagittal cross section, or when I took a periapical, and باصص من الجنب, if it looks straight, it's straight. But very often the canals are curved in the buccolingual dimension. لو جيت بصيت اتكسرت على the maximum curvature. Okay, and usually that's where most of the stress is. يعني أنا لما هكسر instrument وهيتكسر جوه canal, it will always break at the maximum curvature. Makes sense. There's the instrument segment. طبعا this very often when you instrument retrieve, and Mohsen is here and he's a great admirer of instrument retrieval, especially using the kit by Toriucci. So what you have here, when you use tube, there's a perforation. So whenever we do a retrieval attempt for a patient, you have to inform the patient that there is a possibility of perforation. Things could get worse. عشان ما تلبسهاش انت. Okay? Always tell the patient, worst case scenario, you do it well, you end up on top, فانت ايه, you're the king. And then there's the perf, the repair, and then there's the repair, and then the obturation. Okay? So let's imagine there you can see when we do a CBCT, you can see the remaining dentine thickness was about 0.69 millimeters. So if you're using a tube of 0.8 or 1, يعني it's very, very risky business that you could easily perforate in that area. So you have to be careful. Now, هنا أنا من رأي الدكتور that it was torsional. Okay, although it fractured coronally عند الماكسيمم curvature, الحتة الباوند دي هي اللي عملت المشكلة. It was bound in the apical area, وطبيعي جدا مش هتتكسر عند تحت، هتتكسر عند the most point of flexion اللي هي عند الماكسيمم curvature. So torsional fatigue it is. Right, so this was a molarized premolar. One of my students in Canada, he did a treatment for his wife, and he tried his best, and he fractured an instrument apically in the extra canal. So when she said she's coming to Egypt, لو سمحت please could you remove it, and أنا نفسيا أنا تعبان وهي منكدة عليا وهي she's a dentist as well, so she knows what happened. I know what you did last summer. Situation. So there's the instrument segment. And what do you think? Let's go back again. What type of fracture do you think this is? Torsional, cyclic, what do you think? Cyclic? Torsional? Cyclic? Let's see. All right, so there's the situation, and then after removal of the gutta percha, and then there's the instrument segment. You can see it, it's very clear. And then that's after retrieval. So here, obviously, again, no matter how conservative you are, no matter what technique of retrieval you're using, instrument retrieval is a damaging process. We may get lucky sometimes and remove things with very minimal damage, but very often when we're removing instruments, we damage the root, okay? So no exception here. There I re-estimated length, then I obturated. You can see how much of the tooth structure I had to remove from the side. Right? And this is the CBCT, and now you can see how much of a curvature was there, because these type of molarized premolars, they always offshoot. And that's the instrument segment. Again, it's fractured at the point of maximum curvature. So again, here I was thinking, I know this dentist. He's one of my students, a shatter. He knows very well not to apply pressure. The canals after the فيهم, they were quite large. They're not small. So I blamed cyclic fatigue because of the multiplanar curvatures. Right. So here you have, this was an interesting case. You can see right over here an instrument fracture. Okay? And that's what it looks like. It's not very nice. Cyclic or torsional? Huh? How much space do you see around it? Quite a lot of space, yes? So it makes you think. Cyclic, torsional. Cyclic? Okay. Right, so there's the instrument. Fracture segment was exposed, and then it was removed using a tube. What type of instrument is that, ya shabab? Huh? Come on. What type of instrument? What file? A? No. Have you guys never used H files? They haven't used H files, have they? Nobody uses H files anymore. This is an H file. Okay? It's very clear. You can see the cones على بعضها. You have one cone, two cones, three cones. And if you look, the instrument itself طلع بنفس العوجة اللي كانت موجودة في الإكس-ray. What does this mean about this dentist? What did he do? He probably applied force, and it buckled under the force. And these type of files, when they engage in dentine, عاملين زي مسمار البورمة. They don't come out easy. Okay? So that's most probably what happened. And there's the post-op. And here I would say, in my opinion, although there is space around it, this was a torsional fatigue fracture. The instrument buckled under the force and was engaged in dentine. It makes sense, and it's predominantly torsional fatigue. All right, so instrument design makes a difference, whether you have constant pitches or variable pitches in your instrument. كمية الcross sections بتفرق. The more engaging an instrument is into dentine, the more difficult it is to remove and retrieve and bypass. Hello, Awi. So I think this is the last case, so I'm on time. مش كده? Perfect. All right, so this was a Sudanese kid. وقت مشاكل أول ما مشاكل السودان ابتدت وهو نازحين من السودان, he fell over and he broke his teeth. خبط سنانه الأمامية, and I had to replace them back into position again. And he came to me with the swelling. And then when I was doing my treatments, because it's such a large canal, I used an XP Endo finisher file. Right? And the finisher file, if you're not familiar, it's a file which is used to clean canals and not prepare them. And because it's such a large space, there's not a single file that's available in the market that will clean this irregular space. And when I was using it, I fractured it. ليه? Because we love this file so much, we think it will last forever, and we tell ourselves, oh my God, it will never fracture because we're not using it to prepare. And there you can see هنقول ايه cyclic ولا torsional؟ خلاص بقى احنا معلمين دلوقتي cyclic. All right. So let's go back down, and then in this case I had to estimate my position. Now this is a very tough case because any manipulation that you will do here, very easily you could push it out into the apical area. So I went in with a hand file and I started getting close with the repetitive x-rays عشان أعرف my length, and then I did a small little pull, okay? And then I took an x-ray and I realized I'm okay now. The instrument got pulled back into the canal. Now this type of instrument is the worst instrument to be able to remove. By the way, I will remove any instrument bound into the canal easy. This type of instrument is مش قاعد في مكانها. Every time I try to hold it, I can push it up apically, I can move coronally, it move laterally, and especially that this is a very large canal. If it lies on one of the walls, you will never be able to see it through your access cavity. فأنت you have a problem of visibility. So I had to فكر, what am I going to do? In this case, I used the suction. All right, I used the high volume suction. I did something like an endovac, built homemade endovac. I placed the suction device in the coronal, and I started irrigating until the instrument got sucked into the tip. And that's the immediately after removal and after obturation. So if we look and evaluate, yes, you are correct, cyclic fatigue. All right, so take home message right now. The instruments that fracture due to cyclic fatigue are easier to bypass and remove. Don't force instruments during preparation. Increases the incidence of torsional fatigue. Use an instrument kit once. I know nobody wants to spend money on instrument kits. They're really cheap now. زودها على ثمن التريتمنت, but don't put yourself in a position. يوم ما هتبعتها لي أو تبعتها لمحسن هتدفع دم قلبك عشان تشيلها. So it's better that you use a kit and throw it away. Use the prescribed torque and speed. I've heard this many times. Dentists come and tell me, دكتور أشرف أصل أنا حاسس إنه ما بيقطعش فعليت التورك. ما انت كنت جبت لنفسك الوبال. لما تعديت التورك معناها it allows you to apply more force than you will fracture. And finally, be aware of your anatomy. Understand the limitations of your rotary files. They're rotary files, they're amazing, but they still have limitations. Okay, لو حد عنده أي أسئلة, I'm more than open دلوقتي. تفضلوا. No questions? That's it for me.
Thank you, Dr. Ashraf, for your nice presentation. Any question, please? دكتور محمد كنت عايز تسأل قلت لي هسأل. اتفضل. حد من الاورجنايزر يا اولاد.
السلام عليكم، ازي حضرتك؟ شكرا جدا لعلم حضرتك، ربنا يزيدك يا رب. كنت بس حضرتك بتاخد وقت قد ايه بالظبط في فكره الريتريفال او الباي باس؟
Oh, that's a $1 million question. Sometimes I can spend more than one visit. Sometimes, for instance, the case of the last case, it took me about 15 minutes. Okay? The second case, بتاعت a very long 6 millimeter segment اللي كان فيها perforation معاها, it took me 2 visits. So it depends. And each visit could be an hour. أنت وحظك. Right? Because you need to be very careful. And there's also, في نقطة مهمة جدا, instrument retrieval is done under high magnification. So 20 minutes, 30 minutes into the treatment, you start getting muscle fatigue أصلا. My suggestion is if you become impatient and you're beginning to feel your hand beginning to become unsteady, no. Stop, bring the patient next visit. No problem. So you have to be well paid and you have to be well rested عشان تعرف تعملها properly من غير ما تعمل mistakes.
طيب امتى اقف؟ بمعنى امتى احس ان انا النقطه دي عندي انا دي مش بتاعتي؟
Yeah, this comes with some experience. امتى اقول لا this case is no longer a retrieval option, maybe we have to do a surgery. I give it maybe three attempts. 3 مرات بحاول. And if I can't do it after the third attempt, I usually tell my patient that's it, we're not able to remove. وانا اصلا ببقى حاطط الاحتماليه دي من البدايه ومدي العيان بتاعي percentage of success. Usually ببقى مميلها ناحيتي انا. بقول something like and I know it can come out easily 80%, but I would say 60. ليه؟ عشان in case sometimes احنا بنبص على الاشعه and anybody who's done a substantial amount of instrument retrieval هيبص على الاشعه ويقول ايه؟ لا دي سهله. تيجي تتعكلها 3-4 visits and it doesn't come out. وتبقى تلاقي واحده oh my god I'm never going to pull it out and it comes out easy. So really sometimes even with all this preoperative تجهيز CBCT magnification having all this being there still برضو بيبقى الموضوع very shaky.
تمام يا فندم شكرا لذوقك.
العفو.
Certificate of appreciation from the conference to Professor Ashraf Refai. It's our pleasure.